Afternoon and welcome to today's episode of Challenges in the Streets. Happy to be here today live from the Training Academy. In a moment, I'll talk a bit about what the program is and who's going to present and so forth. As usual, if you're a certified chief officer and would like to have COPDI credit, then make sure that you sign in now with your fire service ID and your name, and then you will need to do the same at the end of the program. As always, we like to know if a station or a group of folks are watching. So if we have folks watching from the station, please sign in, let us know what station and how many people are watching. That helps us keep track of the popularity of our program. Before I get started on today's topic, I've been trying to pull up some water supply stuff as we come around, catch people doing some good things. So I happened to catch engine 712. You guys don't mind popping a photo up there. So engine 712, we talked about running these new Pierces and getting multiple supply lines into use. So this is 712 over in Prince George's County, supplying a PG wagon, and you can see that the driver here has done a good job getting both of the large intakes connected up right to the hydrant. Go with the other photo. Right, so he's supplying a wagon down the street. But the bottom line is, we talk about heavy water hookup or trying to get as much water into your pumpers as we can. This was a chance I had an opportunity to catch these couple photos on the Pierce wagon. So that driver did a good job. It was a little complex layout in terms of having to get that line to that engine down the street and so forth, but did a good job. Back to the other photo real quick, just so people can see. Right, so two large lines coming off the hydrant and, supplying the rig down the street. So a good job on that. Those are the kind of things we're looking for. And it was a fire, right? So it was a fire. All right, so that brings us to today. Today we invited the folks from the EMS section in to talk about topics that are relevant to what's going on, especially out there in the streets today, whether you're on an ambulance or a medic unit or you're a company officer who supervises multiple EMS units. You all know what's happening out there in terms of turnaround times at the hospital and all those kind of things. So who better than to talk about that than Battalion Chief Kaufman, and I'm going to let him introduce his guests and what they plan on talking about today. So Chief Kaufman, it's yours.
Thank you, Chief Davis. So I want to start off by saying thank you for the service and dedication you're providing day in and day out there. This has been really a grueling couple of years, and your commitment to providing excellent patient care, outstanding customer service is absolutely recognized. And I keep an eye on these the customer satisfaction surveys that come back. They're overwhelmingly positive, and I know you don't hear it enough, and I certainly don't feel like I say it enough. So thank you very much. I've been keeping an eye on Boss Talks and Challenges in the Streets. I really admire the innovation and the new ways we're able to communicate with folks. So I called Chief Davis a while back with this idea to get the word out more about our alternative care options. These programs have been in place for almost a year, and while there are a few people taking advantage of telehealth and our alternative destinations, it seems that most people simply don't know about them, or maybe they learned about them at annual research and then forgot about it and they just don't do it. So everybody out there who cares for patients, those of you who are supervising patient care on the scene there, really can take something away from today's information that will change the way you think about how we deliver EMS care and the disposition options we have for our patients. So I'm here today with Bridget Plummer from Adventist Urgent Care and Dr. Joel Buzzy from USAC. So let me start with Joel. Do you want to introduce yourself a little bit?
Yeah, thank you very much.
Yes.
Thank you, Chief, and thanks for having us here today. My name is Joel Buzzy. I'm an emergency physician. I work at Shady Grove Hospital. I work for a company called U.S. Acute Care Solutions, and we staff the emergency department with emergency physicians, physician assistants, and we also staff the hospital with our physicians in the ICU, observation unit, and as inpatient physicians. My background, I'm sure a lot of you know, I was a firefighter medic here for about 20 years between volunteer and career. I couldn't really cut it as a medic, so I went to med school.
Sure.
And I'm back here in Montgomery County, happy to be serving the people of the county and happy to be seeing Montgomery County Fire Rescue every day at work.
Great. Thanks, Joel. Bridget?
Hi, my name is Bridget Plummer. I'm a registered nurse. I am the Director of Operations for the Adventist Urgent Cares. We have 4 of them. which are Germantown, Rockville, Laurel, and Tacoma Park. My background, obviously, I know a lot of you. I was an ER director in my previous career. I also traveled as a nurse executive across the United States working with C-suite, as we call them, hospitals to try to provide best care for patients, which was very revealing where I was introduced to this program. My background, I was ER for probably 15 years, another 15 years. I worked in the open heart interventional cardiology program. Prior to that, my father was an instructor for the state for MIFRE. So I grew up around the firefighters and the campus, and it's great to be back on this campus again. So as many of you know that I've worked with in the past, we're family, and we continue to be family, so we're here to help.
Great, thanks so much. So I'm going to start by getting into a bit of background, and everybody out there feels that the hospitals have been busier. We recognize our turnover times have been higher, but I want to put some numbers to it and really show you what's been happening here. So we want to jump back to the slides there. So this is a screenshot of our occurrences of blue alert over the last couple of months, and you can see we've been on and off several times. Typically, the pattern is we're on blue in the evenings. We come off the following morning. You see multiple occurrences here and some over many days, stretching entire weekends or like a Monday through a Wednesday. And this is really reflective of the fact that the hospitals have been on yellow for extended periods of time, and multiple hospitals have been on yellow. There is some fixed criteria that the EMS duty officers use to put us on blue. There is some variability in there, but typically when our big three hospitals, so Shady Grove, Suburban, and Holy Cross, are all on yellow, that is our trigger to be like, all right, if we thought we were in trouble before, now our big three are on yellow, let's go on blue. So this is really reflective of nothing more than the amount of time that the hospitals have been saying, hey, we're really busy, right? If you look at our turnover times, so we measure what happens when you arrive to the hospital in 3 different ways. The first chunk is called turnover time. From the time you arrive at the hospital until you've documented that your care is transferred, that's called turnover. The time from when you arrive at the hospital till you clear the hospital is called drop time. And then the whole time is cycle time. From the time you're dispatched until you clear the hospital, that's the cycle time. So if we look at just at turnover time, the time you arrive at the hospital until you've cleared, you can see over the last 6 months, maybe 7 months, we've been above average with our turnover times. We've set our expectation at 25 minutes, so while our average is still under 25, the last 6 months are quite concerning for us overall. If you break that down into 2-week periods, looking at this since November of last year, you can see a very sharp upward trend, obviously in the wrong direction. So this is measuring 2-week over week turnover times. And then if you look at that, how is that impacting our cycle time? And you can see that increase has been happening as well. And what is most concerning for me is this sustained cycle time increase, especially over the last 4 or 5 months or so. And what this means for the organization is that over time, if it's taking us longer to run calls and if we don't address this increased cycle time, we run lower on ambulances, and we actually need more ambulances to run calls. And that's a huge problem, not just for the organization overall, but the people that have to pay the bills, right? So we have to address this at an organizational level and kind of where the rubber meets the road, and that's where you guys come in. So people think this is all COVID related. It actually is somewhat of a factor, but it's certainly not the root of the problem. Our COVID admissions have been there continuously, but not at a super high sustained level where they were in like the spring of 2020 and then last winter. They are higher, but they are not. It's not a major factor in what we're seeing right now. So Joel and Bridget, feel free to jump in here, but I see this as not having any root problem here. It seems to be, overall, it's related to ED throughput, but that's impacted by multiple things. You have a limited ability to admit patients into the hospital. You're boarding patients in the emergency room, especially behavioral health. I hear constantly from the ED managers that we have more than 10 patients that are waiting for a behavioral health admission, and that really chews up resources for your ED staff. Overall volume is higher. Overall acuity, the patients that are showing up to the hospital are more sick, and then you have staffing challenges, which I can't even begin to imagine how that's impacting you.
You know, you hit it on the head. So as with most complex issues, it's very multifactorial.
Yeah.
And all those things that you mentioned come into play. I think over the past couple of years with COVID, in general, people in our society have not been taking good care of themselves, whether they're not getting out, whether they're not seeing their primary care doctors, and they're coming to the hospital sicker. And they're coming to the hospital in higher numbers. And you're exactly right. It's not COVID-driven directly right now, but I think there's certainly an indirect influence of COVID. We are seeing numbers tick up, but that's just over the past several days or week or so.
Right.
And anecdotally, I was at the hospital this morning, and on the overnight, I took sign out of 10 psychiatric patients in our emergency department, all waiting for beds. So you're exactly correct. That also impacts the system. And then throughput to the hospital. I mean, it's a full hospital house issue. It's not just an emergency department issue. So we need to get our patients to the ICU or to our step-down unit, our PCU, or to the floor. But when those units are full, we're backed up and we can't move the patients out. And again, right on the head. It makes that cycle in the morning. We try to clean up from what happened overnight. We have a little bit of a downtime in the mid-morning where we get some patients' movement through the hospital as patients are discharged, and then in the afternoon it comes to a head. We've certainly instituted some processes to try to reduce the time that first of all you have to wait on the wall, but how long people spend time in the emergency department. We've created an observation unit. That's probably about 4 or 5 years ago. We've been taking steps to use that observation unit more frequently, more efficiently, try to reduce our stays in that observation unit down to about 8 hours at a shot. Instead of always overnight, we can discharge people 24 hours a day. People don't necessarily like to leave the hospital at 1 or 2 in the morning, but if they're able to and they're willing to, we're happy to discharge them at that time to try to get that turnover. It's an entire hospital problem, and then take it one step further. It's an entire system problem. I mean, all the hospitals are feeling the same thing now. So we do try to work together, the hospitals, and come up with innovative ideas on how to reduce our inpatient burden and how to get our throughput up. But right now, to use the word overwhelmed might be a little bit of an overstatement, but we're overwhelmed. We've had more patients and more acuity than we've seen in quite some time. In addition, staffing is difficult right now too. Big turnover in nursing staffing. So we're seeing people and nurses that are definitely dedicated to do their job, but they haven't been working at the facility for as long as the people with institutional knowledge have been there who have left some positions. And that takes time to educate those nurses. And we've had some physician turnover too, and it takes time to educate them as well. So you can see how many different areas are affected and how many different people have to contribute to this throughput, all with a focus on the patient, of course, but also in a focus to get everyone that's in the field off the wall when they come in with the patient.
So when we arrive at the hospital, I understand that we don't get a bed right away. So we could talk about this for the next hour.
Sure.
But what are some of the things that impact the charge nurse's decision to give us a bed right away versus maybe balancing what's happening out in the waiting room, either number of patients or acuity out there?
Yeah, that's the exact balance. So they're balancing what's happening in the waiting room. And when people come in, I used to bring patients into the hospital too. You don't see the waiting room, right? You don't see the waiting room. You don't necessarily see the acuity that we're dealing with at the time in all the other rooms that are in the emergency department, and you don't see the other areas of the department, especially in the departments that have kind of different pods or different areas. And it's difficult to see from the door what's going on. Of course, you see the ambulances that are backed up and the patients that are backed up. So going through the charge nurse mind is what's the acuity of the patient that's coming in, right? We want to take the best care of the patient that's rolling the door, and we never want to make someone sit for an extended period of time. So what's the acuity of the patient? High acuity, we'll find a place. If we have to use the hallway, we'll do it there. But we should be moving very quickly on any priority 1 or high acuity patient to get them situated and get the initial care started. When it comes to the lower acuity patient, the priority 3 patients, that's when people are going to be waiting if there's no rooms available. Because again, it's a balance. It's a balance of the waiting room. It's a balance of the units coming in, and it could even be a balance of other units that are transferring from other facilities into our facility to the emergency department. Although it's fairly rare, we are seeing an increase in that now too. So it's a balance, and they try to walk that line, and they want to move people through. They don't want to make people wait. We own that patient the moment that they roll onto our property, and the emergency doc and the emergency nurses that are there are responsible for that patient, and our hospital is responsible for that patient.
I don't think a lot of people know that. I didn't want to cut you off, but I
Yeah,
don't think
no,
a lot
right.
of people know that when you get to the hospital, that patient belongs to the hospital. It's not your patient anymore.
Yeah.
And it's, we want to be good partners. We don't want to abandon the patient, and we want to have a clean transfer of care. But beyond, we get to these times that are beyond 30 minutes, and I've seen times upwards of 3 or 4 hours in Montgomery County. I saw a tweet yesterday that the units in PG were waiting 8 hours at Doctors Hospital. So it's close. I mean, and Region 3, all of Baltimore is completely crushed, right? All
Yeah.
of these guys are just waiting. So, but it's important that we understand that, we want to be good partners, but there has to be a limit on this.
That pains me to hear those times. It just pains me to hear it. One, for the patient, of course, right, sitting on a cot in the ambulance in a hallway, waiting for a bed. 2, for the crew that's waiting, and 3, for the system. I mean, I live in Montgomery County. If my family or anyone else in this county needs an ambulance, I want that ambulance to be available. So yes, we do own that patient. We own that patient from the moment they come onto our property. And I will say, almost without exception, the crews have been professional in waiting, and they've also been incredibly helpful in helping to clean up a bed, helping to clean up a room even, and helping with critical patients when our staff is in with other patients and staying on to help. I mean, I know they're not credentialed to work in our hospital, but they are credentialed to work in Montgomery County, and we're a team, and they've done an excellent job. I mean, just this morning on a post-ROSC, we had an excellent job just helping out with a couple extra hands here and there during the handover. So we really do appreciate that, and we don't want people waiting. We don't want people waiting for more than 25 minutes. We certainly don't want people waiting for hours.
Right. Bridget, what are you seeing in urgent cares?
So it's interesting, and I just want to say the same thing that Dr. Buzzy is saying. We are just so appreciative of everything you all are doing, and everyone is trying to think outside the box. What can we do? Because the definition of insanity is doing the same thing over and over again and expecting a different outcome, right? So what we've done is perfect segue into this program. When I traveled nationally, I saw this out in the Midwest, which piqued my interest, and I thought this is the model that we have to adapt to. And we hadn't even really had good conversations around it here on the East Coast. We're a little bit slow on the uptake at times, so even before COVID hit, this was something that has been used nationally, and people are starting to pick it up in places like Georgia, obviously Indiana. I think it's really important. We have to think outside the box. And able to do that, as Dr. Buzzy mentioned, we have all these ESIs, 3s, 4s, 5s. We can send them to the urgent cares, and we can get them through. There's no difference than coming in the doors. It's the same process. Obviously, we have to follow those strict protocols of what we can handle. We can't handle, the higher 3s, the 2s, or the 1s. They're not appropriate for us. But if we can help you to debulk the ERs and to reduce the diversion times, we're here to help. It's no different, when they come into the ER, the patient has to find their own way back. There's a phone out in our waiting areas. We can have them use that phone, call a family member, or we can get them Ubered, whatever. So I was very excited when I took this position to work with Ben and push this contract through that had been on the table. And I am very excited about it, and I think you guys should really consider this because we need you in the community. We need you doing your job, and we can help. So this is us thinking outside the box and breaking that rapid turn of insanity.
That's right. Can you break down in layman's terms ESI 1 through 5?
Oh, I'm sorry. The emergency severity index. So 1 is a code. 2 is like chest pain, shortness of breath. 3, you will go in for like abdominal pains. High 3 are things like we wouldn't want to be able to do an ultrasound. If we think it's something like kidney stones or something, a torsion, or we need to make sure we send them to the ER. But outside of that, the low 3s we can do, even fractures. We have x-ray machines in all of our our urgent cares, and we have the radiologist read it. We can do a quick read. Every urgent care center has a provider, has an x-ray technician. At times we don't, I'll be honest. The x-ray technician may call out, or there's a huge shortage of that right now with the radiologist and a medical assistant, and we're all in there. I have some nurses working in Germantown. The majority of our providers are ER doctors, or were formerly, or mid-levels, nurse practitioners or PAs. So they have that blend. So this is where we can help you to get back out on the street.
Great. Let's jump back to the slides there for just a second. I want to kind of make a call to action to the firefighters out there watching, and the EMTs and paramedics. Thank you. So if you get to the hospital, or before you even leave the hospital, you should be considering other options, other care options for your patients. So that means consider eligibility for transport to an alternative destination, or eligibility to use telehealth. If the decision is made to go to the hospital, you have the transport status dashboard, and you have chats to keep an eye on how many units are at each hospital and if the hospital is on diversion. This is still a conversation between you and the patient. We obviously want to consider specialty care needs and any repatriation for previous admission, but we want to get the patient to the best place, and that may not be the closest hospital. If you have a low acuity patient who insists on going to the hospital, absolutely direct to triage. Remember, those criteria are pretty loose. Stable patient with stable vital signs who can sit up in a chair, right? They can go out to triage. You just run it by the charge nurse and head out there. We do want everybody to understand that extended wait times are wasteful to the organization. If you are there 30 minutes, I need you to contact the EMS duty officer. That's assuming you don't have any end in sight. If you've been against the wall and just don't have any plan to get your patient moved, reach out to the EMS duty officer. And I talk with people who say, well, I see that the hospital is doing everything they can possibly do. There is physically no place to move, so what is the EMS officer going to do? And it's a good question, but the answer is they can stop the bleeding. They can stop other patients from coming into that facility and making the problem worse than it is. So they might not be able to fix your direct problem because you see that the hospital is doing everything they can, but they can prevent another ambulance from coming in and making the problem worse, right? We need you to accurately record your transfer of care time, so that data I showed you about turnover time, that's coming directly from your EPCR when you record that your patient has been handed off to the ED staff. Likewise, when you leave the hospital, you need to status AOR as soon as you leave, or DLH as appropriate, right? But really, if you're back at the scene and you have this low acuity patient, we really should be considering other options there. I don't want anybody to walk away from this talk today thinking that they can tell a patient, the hospital's too busy, you shouldn't go. That's not what we're saying. The message is we have other options. Up until now, it really has been, we can take you to the hospital or we can get a refusal. There's never a mechanism for us to tell the patient that the hospital's too busy, but we do have other care options. So you can say to the patient, I've assessed you based on your complaint. You align with this program that we have to call a doctor right here, and I can get them on my phone and reach them 24/7 and have a conversation with you right in your house. Is there a question, Chief?
There is. So I'm sure some of these questions, right, are multifaceted. So do your best. And I have one. So somebody asked, why are we not moving all priority 3 patients to the waiting area after being triaged instead of making ambulances wait for a bed? Doing so will free up stretchers.
So priority 3 is a big classification of patients. We see that happening most often with patients who just cannot sit up in a chair. They're coming from nursing homes and they need to be on a stretcher. And unfortunately, a lot of the hospitals don't have physical stretchers or places for us to go. We end up being the middleman in those cases, right?
Gotcha.
Did you have another question?
No, you're good. Continue on.
Okay.
I was just prefacing others coming in.
I got you. Okay.
So it's
great.
a hot button topic with no easy answer to any of them.
There's no easy answer, but I will point. So I'm going to talk a little bit about direct to triage here. This is a really busy slide, but overall the program has been successful. So this is overall the number of patients that have been enrolled in direct to triage since we started the beginning of February of last year, all the way through when I made this slide a few days ago. When we say the patient is eligible, most often the charge nurse agrees with us, and the time that the charge nurse doesn't agree with us, it's because they have a bed for us right away. So you might radio in the patient's direct to triage. We get there and we run it by the charge nurse, and he or she says, well, we have a bed for you right now, so you don't go out to triage. But we see opportunity that more patients are probably eligible for direct to triage than we're classifying them. So just keep that in mind. If you end up at the hospital with a low acuity patient that can sit in a chair, absolutely move them out to triage just in conjunction with the charge nurse. But you can see that overall the program is successful. We reduce our cycle time by 10 minutes on these calls, so it's pretty good. Yes, Chief.
So countywide data, do you find that there's variances by battalions and shifts?
Yes, it's not necessarily, but I didn't break it down battalion and shift, but I did break it down by hospital. So this is a county-wide slide. I could slice this out and show you that it's most effective at Holy Cross, Silver Spring. It's effective at White Oak. Our upper county hospitals tend to move us through faster anyway, but the places that we generally struggle with turnover times, that's the place for the greatest impact of directed triage. So it's more so by hospital catchment area than shift.
Thanks.
So this is our, really loosely speaking, this is our traditional EMS model. The 911 calls comes in and we respond to the call in an ambulance, either high acuity or low acuity. We go cold, but the result of that is either the patient's going to refuse or we transport the patient to the hospital. Looking forward, though, where we'd like to be is the 911 call comes in, obviously a high acuity response, chest pain, cardiac arrest. We're still going to run lights and sirens through those calls. We're going to run our low acuity calls in a number of ways. If we respond to the scene, they don't all have to go to the emergency department. We have in the red boxes there our options, which are there today. They've been there since January 1st. We have telemedicine as an option and then alternative destinations. Right now, our only alternative destinations are the urgent care centers, so we can go to Adventist Urgent Cares, which Bridge is here representing, and then we can go to Kaiser in Gaithersburg, the CDU, now called the Advanced Urgent Care. But in the future, we'd like to be able to transport patients to a stabilization center or behavioral health center, which we don't have in place right now, but we are in talks with the crisis center to be able to take patients directly to the crisis center. County police do this now. There's a mechanism for us to do it. We just need to work out the details of that. But if you had a patient that doesn't need emergency care in the ED, but maybe they're feeling sad, depressed, anxiety, maybe suicidal thoughts with no plan, the crisis center has social work and nurses in place to be able to take care of those type of patients. The other options for low acuity would be nurse triage. So if we put a nurse at the 911 center with somebody who calls 911 with a very low acuity complaint, we may be able to even avoid sending the ambulance in the first place, so that's something we'll look at down the road, or dispatch something other than an ambulance, being mobile urgent care, something with a mid-level practitioner in a car, maybe with a paramedic, to go handle that complaint right at the scene and avoid the transport. But what we're going to talk about today primarily are the telemedicine and alternative destination options which are in place today. Do you guys want to say anything about that before we get started?
I can just expand out on the urgent cares that I have oversight of. Tacoma Park's 24/7. So in that region, you can transport to the Tacoma Park within the criteria that Ben has and you all have. The other centers are open 8 to 8. We try to not see EMS transfers after around 6 because we're trying to disposition. Right now, our volumes are high like everyone else, but our throughput's a lot faster for the patients. And we have a mechanism called Picasso that we use, where if someone needs to be referred to a specialist, we can do that in real time for that night or the next day for follow-up. So that is just something else to think about with this program that will be a helpful tool.
Great.
Told you it's going to be a popular topic. This looks like it's from a provider. This kind of goes back to your 30-minute deal. This provider asks, would we also notify the EMS duty officer after 30 minutes if the hospital went on yellow after our arrival?
Absolutely. Yeah. So any individual unit that has no end in sight and is at 30 minutes, that's our cutoff time, right? the duty officer has to be engaged, and they may answer the phone and say, yep, I already know about it, I'm dealing with it. But if there's more times that they just don't know about it because the ambulance crew is not calling them, we just need them to give them a heads up.
Got it.
All right, let's jump over to the slides there. So I already mentioned this, but here it is in writing. We have only two options for years. We get a refusal or we go to the ER, and we need other options. So today, you can use your Sonim phone to reach out to, use telehealth, and reach a doctor 24/7 right on the phone, or you can transport to alternative destinations with a little more limitations on the criteria for those patients, and certainly there's some time of day limitations that Bridget talked about. So Joel not only represents Shady Grove, but also here for USACS, which is the physicians group with whom we partnered to provide this telehealth option for us. Our urgent care partners, again, Kaiser and Adventist Urgent Care. We're doing this to improve our care efficiencies in the county, decrease our transport cycle times, and reduce volume in the emergency department. So every one of these patients that doesn't go to the ER and is able to be cared for elsewhere is a win, right? I'm going to skip through a couple of these slides because I think they're pretty straightforward. All right, so the program's overall very primarily intended for low acuity patients or patients who meet these kind of tight criteria. So the patient has to be adult, well-appearing vital signs are within acceptable range, and has no high-risk chief complaint. We want to make sure that, like Bridget said, we don't have a patient that is likely to need a diagnostic test or something that's only available in a hospital. Let's talk about the telehealth specifically for a minute. So both programs work through your identification of the patient as low acuity, and then they have to be able to consent to participate with the program. There's a checklist in eMeds that you'll run through to make sure that you're not missing anything, and then at the end of the checklist, you actually get the patient to sign that they consent to participate with the program. So that's a little bit different than what we do with an ED transport. You want to make sure the patient qualifies for one of these alternative care options, and then they have to consent to participate with the program. But with telehealth, specifically, when that's done, you'll initiate actually a phone call directly from the Sonim phone. There's a standard number that's called Telehealth, or I think it's called Telehealth in the Sonim phone, and it goes to a call down list that either Joel or one of his other partner physicians will pick up the phone. They will initiate a Zoom call back to that phone call. Typically, it's done with a text message and a link to open up a Zoom call, and then the doctor handles it from there. You want to talk a little bit about this?
Yeah, let me kind of walk you through
Yeah.
a phone call and just give a little bit of background information on the telehealth. So this was started by CMS as a great idea long before COVID to reduce a certain amount of low or ultra low acuity patients from coming into the hospital. And it sounded like an absolutely fantastic idea, right? And we rolled it out right before COVID hit, or right as COVID was hitting. And I think some of the lower, ultra low acuity patients kind of dropped off during that time as well. People weren't coming to the hospital. Also, it involves the use of technology, which I have slowly warmed up to over the past year that I've been doing the telehealth and the Zoom calls. Some people enjoy it. Some people would rather not touch it at all. But it's pretty simple. It's a phone call, and then it's touching a link. So, I think pretty much anybody could handle the use of the technology. It can be a little bit clunky if you're in an area where your reception isn't so great. And a couple of my dinosaur docs had to get used to using this technology too. And it might be a little bit bumpy for them as well. So hopefully those bumps will get worked out as we get more numbers. We were expecting maybe 5 calls a day. Maybe, how many calls is that a month? 100 something a month. We've been getting about 5 a month right now. So we're kind of way behind on what we expected and and the care that we thought we were able to provide to the community, and the relief that we could give some of the crews that are out there, and to try to dispo them quicker. So you're right. So the way the telehealth call works is you pick up the phone that's on the unit, you press the button, you get the link sent back to you after you get in touch with the physician. From the physician side, we could be doing anything when this goes off. Usually we're at home. Some of our physicians are working in the corrections facilities in the state of Maryland right now. If they're on call for that or they're available, they may be the one taking the phone. I'm kind of always the default doc on this, almost 24 hours a day, 7 days a week, and picking up the phone on these. So I'll pick them up fairly often. But it's real simple for us. Phone rings, we pick it up, we send that link out. We can look at the patient live on the screen, and we'll take you through some patient assessment tasks. In the beginning, it is a little awkward. We have to go through a couple of legal things when we start off. We have to go through a patient consent. We have to tell them that we have a privacy statement that the patient can access at any time on our website. We have to explain that to them. And then we also have to tell them that they may receive a bill. CMS will cover this. Some of the insurance companies will cover this. But the largest bill the patient would possibly receive from my company is a bill for $100. And it's not hard billing. It's very soft billing. We're not going to go after someone for that $100 after we've taken care of somebody. And then we can start the call. The things that we need from the providers in the field, we need a run number, we need a name of the patient, we need a phone number for the patient, and if we can get the address, that's great, but it's not 100% necessary. The other things for assessment that we need a good set of vital signs. And then I always like the overview of the patient from what the medic or the EMT is seeing. Just what's your general overview? I mean, I can see a little bit on the phone, but having a person give me what their full assessment already has been will help set us up for success and getting some good information. And then we might have the patient, we might want to watch the patient be walked. We might want to have them press on the patient's belly. I'm a stickler for neuro exams, so pretty much any patient, you're going to do some type of a neurological exam to make sure we're not missing something that's underlying. And then also family members. We can involve family members in the conversation. We'll want to know patient's baseline status. We may ask for things like a finger stick or an EKG if that hasn't already been done. And then we'll come up with a plan. And the plan definitely includes input from the fire rescue side as well as the patient, as well as the patient's family. Because at the end, I want everyone to be in agreement with what we're doing with the patient. And we'll come up with a treatment plan. Now, the treatment plan might be, hey, this patient needs to go to the hospital. And if the patient's refusing, we can try to help convince them. We've been successful with several of those cases. The plan might be, hey, this is a great patient for urgent care. And we'll refer them to go to urgent care to be evaluated. And then the ideal plan is, hey, we can take care of this over the phone or be it via telehealth now, and we're able to prescribe something for the patient. Now, we're not going to prescribe narcotics or complex medications for the patient. We could do some type of medication refill if necessary. We're comfortable with that. But things like anti-inflammatories or medicines for a simple urinary tract infection, some odd rash that the patient has that we're able to figure out what it is, we might be able to assist with that. But those very low acuity, hopefully we can disposition those. What are the barriers to it being successful? The technology is a little bit of a barrier until people are comfortable with it. It being used because it's something new, I think, is also a barrier. Patients might think, hey, I called an ambulance, I want to go to the hospital. If that's the case, sorry, we were not going to be very helpful to them. Right. But I think getting it accepted is probably the biggest barrier, accepted by the providers in the field, and ask them to use it when they feel it's appropriate.
Sure. So we did extend the use of telehealth rather than just limiting it to the low acuity patients. We got a couple months into this, and Joel, you and I talked about maybe using the telehealth docs as an option to help convince that patient to go to the hospital, especially the high-risk refusals, right? So we added in the high-risk refusal process and using telehealth as the primary mechanism for intervening with a patient who's home with chest pain or shortness of breath and saying, I just don't want to go, or I'm scared of COVID, or whatever the reasons are. Our traditional ways are we'd obviously be on the scene, talk them into it, or get on the phone through a consult and talk with a doc, but that's somewhat limited, right? You're talking over the radio to somebody you can't see. Put the doctor in front of the patient and let the doctor face-to-face say, you need to go to the hospital, you're going to die, right? You have success stories with that?
Yeah, we have. When you see the doc face-to-face, they understand that we're all on the same team. The doctor can explain, hey, it is a pretty low risk of any type of COVID exposure in the emergency department. We're going to keep you safe. Hearing yet another person say, hey, listen, I think you should go to the hospital, and seeing them and, calling the person doctor, our mysterious patient assessment skills and our mysterious powers, they might feel like they, feel more convinced that they should go to the hospital and be seen. They do have to consent for the call, though. So they do have to say, hey, I want to talk to the doctor. And they do have to go through our consent process, too. If they won't do that, then it's back to the normal process of going through an EMRC consult. But this also, if you come to us, if you use us for these high-risk refusals, it does relieve a little bit of burden from the emergency department to have to take that call when during a busy shift to listen to the high-risk refusal and discuss with the patient or discuss with the caller or the medic that's calling in. And we're very willing to take that. We're all, like you said, ER doctors. We're all base station trained. And that takes a little bit of pressure off the consults that are going on in the emergency department.
And then, can you give us a couple of examples of, if you go to the slides, there's a list of chief complaints that would be suitable for telehealth overall on the low acuity side. So have we had, you want to talk about a couple of good cases that we've had?
Yeah, so a couple of ones that we've had that we've been able to reduce the transports, simple urinary tract infections. That has been certainly an area where we've been able to treat a couple of patients, kind of vague, generalized weakness without any mental status changes has also been an area. We haven't seen a lot of minor trauma though. Surprisingly, I thought we'd see some more minor trauma, and we're very happy to take a look at that type of patient. You know, the type of patient who initially thinks they're really hurt, but in the time that it takes the ambulance to respond, things settle down a little bit, and we can certainly interview a patient and set them up for a successful treatment plan after that.
Great. Thanks. Chief Davis, you have something?
Got a statement and a question. The statement that, hey, on the Sonos, it's called MCFRS telemedicine.
Thank you.
That you contact. Now I assume that's correct. Whoever wrote that in.
That sounds right.
Looking at the name, that I trust that name. But, and the other, now we have a question, and you may or may not have a good answer for this, but for the telehealth calls that have occurred to this point, what's the percentage of dispositions, meaning emergency room, alternative care, or stay at home?
So I haven't run, that's a good question, but I haven't run the numbers specifically. They are, they're broken down into the reason the telehealth call was made. So was it always a low acuity call with the intent of not being transported? I think more often than not, the use of telehealth is for the high-risk refusal. I think, would you say that that's what you're feeling?
Right now, that's the majority of our calls.
I didn't bring any data to support that, yeah.
Can we ask the same question about the alternative destination percentage-wise, like transporting there, them staying there versus us going back to take them to a different facility?
Yeah, so I do track it. Our number, our N in this whole program is so low that the data is not going to be worth anything right now. Initially, we did, I think, more than I would have liked to see. Our patients that we took to urgent cares were being transported to the emergency department later on. But I think that's working the bugs out of the system, right? Mm-hmm. So, and that has tapered off now. We've been much more successful in more recent months. I think and like I said when we started, there's pockets of stations and people that are using the programs. The people in Gaithersburg and Germantown are going to Kaiser regularly, whereas Adventist is available countywide, and I feel like our uses of Kaiser is much higher than what's been happening at Adventist. So, but I don't have any specific numbers because
these transports, I apologize,
yeah.
Are they through MCFRS ambulances or private when they are transferred from your facilities? Are they?
Sure. So we have had a few at each center, and our goal, our matrix, is to get the patient in and out in 60 minutes. That is what we look for. We have had some, it's learning curve on both sides. Some of it's ours that, our providers have to get comfortable with. Remember, this is new for them. So just like it is for you, and every one of them we work through. We have a meeting every 2 weeks. We triage it internally with my leadership and talk about what can we do differently than the ER. Example, someone has an ortho. We have a lot of fractures that come in or suturing. It's not like when they come into the ER, they're going to see the orthopedist that night. Those days of medicine are over. So we're doing exactly the same thing, seeing the patient, and then getting them to the specialist as fast as possible. So we have had some really good success stories coming out of there. A lot of them were mechanical falls, I would say, shoulder injuries, knee, ankles, some suturing, and we can get them in and get them out pretty quickly. As for the data as percentile, we don't have that to give right now, but we're looking to do more to help you.
So I guess another valid question, this is a Chief Davis question, right? How long does the telehealth call take, right, to resolve? And could I have been to the hospital or not?
No chance.
So,
No chance. So even
right, so I mean, in today's world, like, hey, I could probably do 5 telehealth calls and, right, still have,
exactly.
Right.
Even if a call takes 20 minutes, which would be extensive, right?
Yeah, usually they're about 10 to 15 minutes in the call. If it's a refusal case, it's much quicker.
Yeah.
But if it's usually about 10 to 15 minutes.
Yeah.
I think you're going to find telehealth now. We were trying to get it pushed before COVID. COVID was the synergy to really get it into place. And it's really widely acceptable now. I know they're doing a great job with telemedicine through USACs and other areas. We used telemedicine and as well as some of the providers. And we're looking at expanding that into behavioral health, so more to come. But again, this is all COVID that's the gold lining in COVID, that we're going to be able to do these things.
You know, medicine's expensive, right? And hospitals are really expensive. And taking a patient to the hospital is intuitively smart, right? That's where the physicians and APPs are. That's where the care is given. But it's incredibly expensive to run a hospital 24/7. And it's much less expensive to run these telemedicine visits or have a provider in the field, whether it's a medic or whether it's a physician assistant or nurse practitioner. And we're seeing a lot of medicine being pushed to the home. And whether the ET3 telemedicine is going to be an answer to this or not, time will tell. I think it's going to morph into something else as time moves on. But for medicine in our current operating, the way we currently operate is not sustainable. And we're going to have to find easier ways to make this work and cheaper ways to make this work for everybody. And we always have to keep the patient in mind as our primary patient and as our primary customer as well. And I see, you're exactly right. I see many aspects of telemedicine. It is a slippery slope of not having providers in the field touching patients. But I think that having a physician-directed or APP-directed provider in the field doing their job, assessing patients, relaying information back, is really a good model. And I think financially, it's going to be used much, much more in the future. Maybe hopefully we have a USACS, Montgomery County Fire Rescue providers that are going out into the field to take care of patients at some point.
Let's do it.
But we'll see. That's down the road. But we'll see how things go. But it's the future of medicine to a certain extent.
Let's jump back to the slides for a second. And yes, Chief Davis.
2 things, right? So don't get, I just sent out a little message that, hey, given the interest here, we may go a tad bit longer than expected. So 10, 15 minutes extra allocation if needed. Somebody asked, and you may have kind of answered this, I wasn't sure, cost-wise, how does urgent care compare to the ER?
So
Yes, at the end of the patient, right, for the patient.
Sure,
right?
sure. As Dr. Buzzy mentioned, there's a lot of layers in the ER and in hospital. So the cost to the patient who are utilizing the urgent care is much lower. I can't give you, the CPT code. We still use the same type of billing that they do at the hospital, but we can bill that in an outpatient, which is totally different from what they have to bill. So it is significantly lower, but again, don't let that be the driving force behind it, because the first point that we have to do is patient safety. But it is a nice, it is a nice perk to this, that the patients won't be saddled with a large emergency room bill versus a urgent care.
Okay. Did you have one other thing?
No, go ahead.
Okay, great. So I'm going to talk a little bit about inclusion criteria for alternative destinations. They are directed by MEMS protocol, unlike the telehealth criteria, which we came up in conjunction with a conversation with USACs, right? But the alternative destination criteria are driven by protocol. They are by design more restrictive than the criteria for telehealth. We want to make sure that we are doing everything we can to make sure that that patient is eligible to be treated effectively at an alternative destination without needing that secondary transport. We understand that there still will be secondary transports, especially as we work the bugs out through the program. But The criteria are driven by protocol. They are in an eMeds worksheet straight out of the protocol that you'll see when you work through your worksheet there. So this is a map of our availability for alternative destinations now. We have Kaiser CDU, or now Advanced Urgent Care, on Watkins Mill Road in Gaithersburg. We have the 4 Adventist Healthcare Urgent Cares. And then starting in 2 weeks on January 3rd, Right Time was purchased by MedStar Health, and we have 2 of their locations coming online. One is in the Park Potomac area, and then the other in Bethesda and Stanford. So really opening up some opportunities for South Battalion 3, Battalion 2 to have an alternative destination that really we didn't have before. And I mentioned that we're in conversation with the crisis center in Rockville to be able to take patients there, and that would be a 24/7 option. Yes, Chief.
Battalion 1 runs a whole bunch of calls into Prince George's County. Is this an option for those calls in Prince George's County?
Yes, sir. Yep. You can take patients to Tacoma Park Urgent Care
Laurel.
or Laurel. Yep. So I want to mention this here because I have everybody's attention, but this is not done under the umbrella of alternative destinations. Actually, in the current Maryland protocol, we can take patients who are qualified hospice patients of Montgomery Hospice who are DNRB, and they call 911, and they may call 911 out of not knowing what else to do, right? They're already in hospice. They know, their family knows that they're dying, but they are at a point that they cannot care for the patient at home anymore, or they're experiencing a level of pain that they just can't manage. So Montgomery Hospice approached us saying, we have somewhere between 5 and 10 patients a month that are happening in Montgomery County, and they call 911. These patients end up in the emergency department or even admitted to the hospital. And Montgomery Hospice would look to avoid that transport to the hospital and have patients stay in their hospice network and take those patients directly to inpatient hospice, which is in 28's area on Muncaster Mill. So Casey House, a wonderful facility. We're in final talks with them to be able to do those transports directly there. They're 24/7. The mechanism will be similar to what we do with our alternatives, meaning you should call them. You have to call them before you go. They'll just confirm that the patient's eligible, that they are in network with Montgomery Hospice, that they are a DNRB, and that a bed is available. But that would, this is, again, avoiding an unnecessary transport to the hospital and getting really the patient to the right place at the right time. I just put a couple of slides in here on accessing the worksheets here in eMeds. So there's a separate worksheet for the alternative destinations that's labeled ADP, and then Telehealth is another worksheet in there. These are the slides specifically for alternative destinations. Adults only, we start by looking at the inclusion criteria, meaning acceptable vital signs. You'll see the very narrow range of blood pressure there. That's, again, driven by state protocol. The patient has to be able to consent. We exclude all high-risk conditions. We look for time-dependent needs and exclude any of those. And then the last step is really for the patient to consent and sign the way they would with either telehealth or alternative destination transports. There is an alert in the MEMS protocol that gives us an opportunity to go with our gut feeling and really take a patient who doesn't meet these criteria, these very strict criteria, and still take them to an urgent care. It requires a base station consult, but the example I put up here is a patient with a very isolated complaint, low acuity, but their blood pressure may be slightly out of range. You can call and get a consult with a base station doc to say, this is what I want to do, and just make sure they weigh in. And again, you have to call the urgent care before you go anyway. To run it by them and make sure that they're good with accepting the patient. So I put a couple of links in here. These are off of quick links. You can find these there. The main thing is this field resource guide, which includes links for you in real time to go access, and you can do this from your device, from the Sonim phone, from the eMeds computer, from the CF20. You can get to this resource guide and be able to look up the phone numbers, look up the criteria, and any questions you have about the program. They're at your fingertips while you're out there running calls at the patient's side in their house before you make decisions here. Obviously, the duty officers are spun up. If you have any questions, you can reach out to me about these programs. I just want to reiterate that all the stuff I went over about the hospitals being busy is not a green light for you to tell that to the patient when you go and assess them, right? We don't want to say that the hospital's too busy to see you, you should stay home. The hospitals are busy. That is a fact. But what we're gearing towards and what I'm presenting here today are other options for your disposition of patients. It's not just the hospital. If they're low acuity, you can reach out to telehealth and alternative destinations. Yes, Brady.
And you touched on this earlier, the direct to triage, and I apologize for not knowing, but where is that addressed? I mean, can you kind of walk that? It almost seems like direct to triage is, I know it's not an alternate destination, but it seems to me that it would reduce our cot downtime, or the wheels on the street or
Sure.
cots or whatever it is that we're calling it this month. That's a very valid thing. Can you kind of talk a little bit more about that?
The direct to triage program has been in place since the beginning of 2020. It was distributed through email, and it was pushed out through training. The criteria are very loose, so if the patient is stable and can sit in a chair, so that limits your nursing home patients who have to lay on a stretcher, right? But for your patients who are low acuity and don't have any time or urgent needs, our protocol for direct to triage is we check in with the charge nurse. We identify from the field that they are direct to triage. We run the case by the charge nurse, and if they are on board, they give you the thumbs up. And then rather than you waiting for a bed in the ER, you take the patient out to triage, sit them out there usually in a wheelchair, and then you run the case by the triage nurse rather than transferring care back in the emergency department.
And do you personally feel like listening to all of this today, that seems to me to be a very valid underutilized option?
You have to remember that the patient that ends up in the waiting room at a hospital is still going to eventually take up a bed in the emergency department, right? So if that patient can be treated in another way, effectively in another way, not secondary like this is, we have just as good a way to take care of you, talking to the patient without going to the hospital. You're going to be waiting there for a long time, and then let's see if we can get this done another way. We didn't talk about the success we've had with the turnover times at both Kaiser and Adventist. I think our average time into the facility and leaving is 11 minutes, whereas that's...
The whole 60-minute thing is amazing.
Yeah, we're in and out of the alternatives really quickly. And it does, with direct to triage, our turnover times are lower as well. But remember, that patient is still going to eventually tie up a resource that needs to be available for our sicker patients and the hospital to take care of sicker patients. Yes, sir.
Someone asks, could you take a stable ETOH patient to an alternative destination?
No. So unlike the ER, we are not equipped to take care of substance abuse, behavioral health patients. We're limited. But again, stick to the criteria that we have outlined in the program and you'll be safe. But again, we don't have narcotics in our urgent cares. But with that being said, the other side of that is we don't have narcotics in our urgent care, so we don't have that clientele coming through. So we can really focus on patients that are coming in with minor injuries, like Dr. Buzzy said, some pain, just, again, the emergency severity index of the low 3s, 4s, and 5s, which you're already discussing. We can effectively and efficiently get them through the system.
Okay.
Tech guys, you want to run? I have a testimonial from a couple of fellows at Station 8 who had good experiences with Kaiser. Do you want to run that for us? Chris and Sean from Station 8, welcome guys. Thanks for being here.
Thanks, Chief.
Thanks, Chief.
So I hear last shift you guys were riding an ambulance to Station 8 and went to Kaiser through our alternative destination program. Not once, but twice. Can you tell me about that? Sean, why don't you start?
Yes, so our first call when we encountered it, assessed the patient, talked to him, found out what was going on, decided that the patient would be appropriate to go to Kaiser. They were a Kaiser patient, and they were in agreement upon that to be transported to Kaiser. It was the first time that myself transported to Kaiser along with Chris. So we go ahead and we went through the process and did it. I made the phone call to Kaiser with the Zellophone. Chris obtained vitals, started with patient care, got that all completed. And it was, decided that the patient would be at Kaiser, and it would benefit the patient 100%. To Holy Cross Germantown would be the hospital of choice if we could not go to Kaiser.
Got you. So when you called on the telephone, somebody picked up right away, knew who you were, and wasn't out of the realm that an ambulance was going to be bringing the CDU a patient. Is that right?
Correct. So everything went super smooth. We called, just went into the Zellophone, typed in KAI, Kaiser came up, CDU. The last 4 digits of the phone number was 4444. The phone rang to the triage nurse. She answered. I gave patient's age, date of birth, the patient's name. Kaiser needed to verify that they were a active Kaiser patient within their system. The nurse verified that they were an active patient, told them what was going on, and the nurse said, go ahead and bring the patient right up to the CDU. So we arrived at the CDU. Security was waiting for us. We use a entrance on the Bravo side of the building now because to the rear of Kaiser, they have COVID testing and COVID vaccine going on. So we no longer go to the rear. So security was waiting for us. They escorted upstairs and we performed transfer care then.
Awesome. So, Chris, any issues with the transfer of care? Were you able to get the signature right away? And then about how long did it take to get all that done?
All in all, is about 5 minutes. You take the patient straight to the waiting room, and the charge nurse has you come right up to her. You give her your story, and then she gives you a signature. So it was pretty quick. And they seemed pretty open to the whole idea of what we're trying to do.
Awesome. And then you had a second call later in the day, huh?
Yes, sir.
How did that one go?
Same. Real easy. They just have to confirm that the patient's a Kaiser patient, and they tell you to bring them.
Great. Cool. You telling all your friends about it now? I know it just happened, but as busy as the emergency departments have been, you think this is something that people just don't know about? And if they did, it certainly seems like we're going to be able to turn patients over faster, whether we're transporting to Kaiser or to another urgent care somewhere. Yeah.
I know there's some resistance to Kaiser because of some of the calls we do run to Kaiser and transports we do out of there. So I know a lot of people hesitate about going to Kaiser because not only are we going to run one call, is that are we going to go back for that patient and transport them out then? If they're a stable priority 3 patient, check up after a fall, check up after a PIC, Kaiser has a lot of capabilities to do medication, all that. People want to go there. That is their choice of hospital per se. Whereas if they go to Holy Cross Germantown or Suburban, they're seen, they kind of put a Band-Aid on it, and then that patient still needs a follow-up with Kaiser. So if we get them to get them to Kaiser, to the facility, let Kaiser deal with them 100%, it's all done in-house. Hopefully we're not running these people 2-3 times, for calls.
No, that's fair. I mean, the patients that we're taking out of Kaiser, though, are a higher acuity complaint. So I'll tell you, I mean, we do run a lot of calls there, but they're chest pain calls, trouble breathing calls, people that would not qualify to go under the alternative destination program anyway. The criteria we have set up are pretty safe. Generally isolated injuries and general illnesses that are pretty clearly not going to require hospital admission. So cool. Anything else to add? Great, Chris.
No.
I think Kessler covered it pretty well.
Super easy, super quick.
Yeah.
It made our life so easy.
Especially with how busy the hospitals were that day. It definitely saved us a lot of time. Especially if you're at Station 8, the surrounding stations, it's right around the corner. So it's a good alternative.
Well, fantastic. Thank you both for sharing your story with everybody.
All right, we're going to close it out from our side here. Joel, thank you so much for being here.
It's absolutely my pleasure. Keep in mind, this is a new program. We're getting through this too, the telehealth. Most of the docs have had telehealth experience, but they're learning from it too, as the providers in the field are learning from it. So I'm happy to take any feedback if there are any issues. Certainly, if there's any problems, let me know right away. It's really an honor being back out here, and I really appreciate you having me. Thanks a lot.
Well, welcome. Thank you, Bridget.
I echo the same sentiment that Dr. Buzzy says. Please reach out. I'm happy. I want to keep this going because it's only going to help you, and that we're a team. So a lot of you can reach me through Ben. I know a lot of the duty officers have my cell phone number. Feel free to call us. We're here to help. It's not going to fix all your problems, but at least we can start shaving away at this to try to help, and we'll keep thinking outside the box.
Absolutely. So we have Adventist, there are 4 places. We got Kaiser, and now coming online in a couple weeks, you have the MedStar Urgent Cares in Potomac and Bethesda. So thank you, Chief Davis, for the opportunity to speak, and I'll turn it over to Captain Miller to close us out.
Chief, thank you.
Yeah.
Joel, thank you. Bridget, thank you for coming in. Just a quick reminder before we close down here. Again, if you're a certified chief officer, don't forget to sign out with your fire service ID. And then coming up January 10th, the next Boss Talk episode will be from Company 34. It will involve our EMS duty officers, kind of the who, what, how, when, why. We need them, what they do. As a company officer, how can I utilize them to help me accomplish things? So until next time, thank you. Stay safe.